you everyone for submitting questions. Having the opportunity to submit them in advance gave me some more time to kind of research and connect with resources if I didn't specifically know the answer, which happened for a few things. So some of this is based on, my experience and my training, and some of this is based on, I did some additional research and can link you to where you need. But if there's other questions that came up in this last hour, definitely feel free to include those in the chat, and our text will forward those to me so I can answer those verbally as we're going through, because I can't actually kind of see you guys or the chat while I'm presenting, so that is why. So you asked, we answered, or did our best to answer. Questions about autism. I'm getting this one out of the way. Oopsie. Oops, I'm going too fast. Do vaccines cause autism? No. Just no. That one study was later refuted. There's all the research out there that shows that it's not. And some things you could say to parents when they express this concern, but no. Can autism be diagnosed in adulthood? Yes, but the characteristics must be present in childhood. So late diagnosis often occurs because these characteristics may be present, but not severe early on. So maybe they have some problems with social communication. Maybe they do have some unusual behaviors, but it's not as obvious. And it's not until, and they also might have other compensatory strategies they're using to get by and get their needs met. They might be really intelligent. They might be strongly verbal. They might have good supports. But as they progress in development and as demands increase, it kind of reaches this breaking point where it's not enough and they're having some severe problems. So assessments in adulthood needs to include corroborating data from childhood. I often like to do parent and caregiver interviews, just to have someone say yeah, this is what they were like as a kid, answer specific developmental questions, especially if there's questions about early childhood that individual just might not remember. But lived experiences are really important. And these additional information and data, like school records, medical records, are important as well. How do we discuss an autism diagnosis in individuals where maybe they're not initially presenting with this concern? Sorry, just checking to see if we have any other questions. Sometimes individuals present with referral questions like they're maybe wondering if they have ADHD. That's a common co-occurring disorder, social anxiety. But you as a provider might suspect autism. And that can be challenging to bring up if that's especially unexpected. So ways to do that include sticking to the observed behaviors, like what concerns are they specifically sharing and how can you tie those to signs of ASD? Like, oh, you said you struggle so much with feeling like you have to wear a mask in social situations, like you can't totally be yourself. You're really on your guard and trying to be on all the time and it's really exhausting for you, right? Like maybe there's some things going on there. Also emphasizing just openness, like presented as something to rule out or to consider just in case, but we can't know for sure without further testing. I do that especially with questions with ADHD, these do overlap a lot. So we just need to kind of at least screen for this to have that comprehensive evaluation and connect them to resources, like encourage exploration of information, see if that resonates with them, like learning about other people's lived experiences, and maybe that provides some insight to things that they previously hadn't even thought of, or maybe it doesn't. Maybe they're saying, no, this is not me at all, and that's important too. I know I put adults on this question because that was the question asked, but with kids, that's more of a conversation you're having with parents at first, but similar processes, sticking to the observed behaviors, what are they concerned about, and connecting it and being open to ruling it out. Who diagnoses autism? That could be psychologists, neuropsychologists, developmental pediatricians, pediatric neurologists, child psychiatrists. These are the professionals that have the specialized education and training in diagnosis. So even though other mental health professionals or other individuals might suspect autism or think it kind of looks like that, it really requires more of an evaluation. And if we're trying to figure out where to obtain that, the Asperger's Autism Network Directory is a really great website to look at nationally. And then Utah has this really great resource, like all the centers that do autism evaluations too. How we diagnose it, a few different factors. Developmental history is key. There's a lot of valuable information you're going to get in there that you can't really get any other way. So having a good clinical interview. And there are some structured interviews out there, like tools that are more standardized, getting corroborating information from educators or healthcare providers, and then observational measures, looking at cognitive testing, because as we've talked about, there's a lot of other things like ADHD or learning or giftedness that can look like autism. So we really do kind of need additional cognitive information to conclusively rule those out. And then observing social communication and reciprocity. The gold standard tool to do this is the Autism Diagnostic and Observational Schedule, or the ADOS. And a person in the audience asked, is this required or do you recommend this? Something like that. And one, it's not necessarily like a requirement to diagnose. It's a really useful tool. I do recommend it. There's a lot of things that it pulls for that you're not going to get in other contexts because it requires a lot of like social back and forth. There's certain tasks that might prompt repetitive behaviors or special interests. It gets them to talk about their emotions and their relationships in more depth. When outside of that, they might be able to kind of answer more surface level and avoid those things. So I think it's really valuable and important across all ages. And there are some insurance companies that require an ADOS and a diagnostic assessment in order for them to cover services. So sometimes it is more of a systems level choice rather than clinical. Then also just several questionnaires. We want to look at social behavior, we want to look at adaptive functioning, we want to look at just general psychosocial mental health concerns, because as we've talked about, there's a lot of overlapping, anxiety, mood, other psychiatric disorders, especially the later we diagnose autism. So we want to be screening for those things as well. Some questions about why rates are increasing, and there's a lot of, again, hypotheses about whether this is like an actual increase or there's just better recognition. And there's a few reasons why, is because the diagnostic criteria shifted in the 90s and again in 2013. Special education classifications didn't even have autism as a separate category until the 90s, so there wasn't a lot of motivation to test for that specifically in order to get services at school. They were just kind of subsumed over intellectual disability. And the standards for pediatrics changed to include increased screening for autism, or just in general more aware, increasing access. And so prevalence itself is not necessarily increasing, we're just better at identifying it. Utah is higher than the national average. We don't really know why for sure. Some theories include there's changes in the way we're measuring that in the population over time, just some differences in data collection. Some advocate that we are improving our access to resources for diagnosis across different levels of the population. And there might be a higher occurrence of risk factors associated with autism in Utah, including things like exposure to environmental pollution, having many pregnancies or spaced less than 1 year apart, or pregnancies, longer lifespan, and some genetic factors that might be at play here, which that's not unique to autism. There's other genetic disorders that are pretty prevalent here in Utah. So yeah, some theories. Someone asked how we can improve identifying girls on the spectrum, because yeah, as we've talked about, it does present differently across the gender spectrum, and most of what we understand about autism is based on male presentation. And so individuals who are girls, who are assigned female at birth, they tend to have different characteristics like less repetitive behavior, stronger verbal skills, more social motivation, and they might not show the deficits until middle school or high school when relationships are more complicated, and they're better at kind of masking traits and camouflaging with peers, and that requires a lot of effort and really draining in social interactions. So recommendations include referring for assessment even when screening tools aren't quite at that clinical threshold, looking at the quality of relationships rather than the presence or absence of friendships, and comparing girls suspected on the spectrum to what we would expect for typically developing girls, not necessarily to boys on the spectrum, are some suggestions, but we do have more resources on that linked in this presentation at our website. Someone asked if autism can be cured. Like, technically, no, there's no cure for autism because it's not necessarily a disease. It's a broad category of neurodivergence. It has genetic underpinnings, neurological underpinnings. However, with intervention, individuals can improve their social skills and decrease their repetitive restrictive behaviors. And diagnoses are based on observed behaviors and impairment in functioning. So if individuals can change their behaviors and successfully navigate their world to get their needs met, there's no impairment, and therefore no diagnosis necessarily. Some individuals in the autism communities argue that there are people that are just better at masking these traits. It takes a lot of effort and energy. And many people who appear like they lost their autism diagnosis continue to struggle with some attention issues, regulating emotions, and flexibility. It's just much less than before. So technically, no, it can't be cured, but the autism diagnosis might go away. Where should intervention begin once we diagnose? And that really depends on the person and the needs. If they're in school, their child or a teen, or even in college, educational supports are key. But think about what in daily life is hard. Like, are there speech and language needs? Are there occupational therapy needs for like significant sensory processing concerns that are getting in the way? Social skills groups or activities that provide opportunities for interaction, activities in line with our interests to find other people in common with interests are really important. Late diagnosis also includes significant mental health concerns, especially the later we're pushing it off. So looking at services for mental health disorders, medication, and there's got several guides online with, okay, you just got a diagnosis and what are the next steps? So I recommend looking at those, but those are some areas to start. And we have a couple of questions in the audience. One was people who worked in different settings or been working in these individuals who didn't receive an autism diagnosis were not able to access disability services if not diagnosed prior to age 18. Is that still the case? That I think is very state dependent. I would have to double check on what Utah's rules are, but I recommend contacting the disability service organization in your specific state, looking at their criteria. But usually if you can prove that it existed all the time, we just didn't get the diagnosis, that's enough to justify the validity of the diagnosis, but everyone has their own criteria, bureaucratic organizations. So that depends on the state. Another question is, given that the ADOS, or that measure I talked about, requires specific training and certification, are there other measures and tools clinical psychologists could use to evaluate autism in young adults? Yes, there are several structured interviews, including the Autism Diagnostic Interview, the ADIR, one that's called the MIGDAS. I don't remember what that acronym stands for, but there are structured interview tools, and you can get a lot of corroborating information from parents, from past teachers, from medical records, and there's things you can observationally note just in other ways of assessment, like when you're doing the cognitive assessments and when you're doing the academics, if you are like, there's a way of interacting that comes across that you can just use your clinical observation as well to see if it's present or not. But yes, like you can diagnose autism without the ADOS. I think it's just a really valuable tool that I recommend learning more about and getting that training in if you can. And some insurance companies, in order to provide services, require that tool, but it's not a requirement. And another question from the audience. Is there a higher comorbidity with autism and suicidality? If so, why? So it depends on what the diagnosis is with that suicidality. When I mentioned it at the talk, if there's a co-occurrence of like borderline personality disorder, which includes a lot of suicidal behaviors within that diagnosis, and autism, those co-occurring diagnoses have higher risk of suicide compared to neurotypical individuals with BPD. I also have someone asked a question about substance use that I have a slide on that I will talk about there, but there's higher mortality with substance use and autism compared to substance use without autism. So it depends on what the diagnosis is and why. That is even more unknown because there's not enough research on that. Like we could theorize that it's like, well, they have a lot of problems with social relationships, and that is a big risk factor for suicide if we're more socially isolated and less engaged with others, right? Or more impulsive behaviors or repetitive behaviors, right? So research doesn't quite know the answer to that question. A good question. Okay. How can parents advocate for educational testing and accommodations through the school for children with ASD? Sometimes if there's a barrier where like if other providers don't think it's autism, that could be really hard. So definitely know your rights with advocacy. There's different groups that can help with that. Every states have their own agency. The Utah Parent Center I linked here is the one in Utah, and the Autism Society website can provide a directory for like your specific area. So getting support in there. If they're not getting accommodations or testing through the school, you can get it outside the school and then present that report to the school. But there's different rights depending on if the school is a public school or not that you have. But having either like if you have a provider already, say you're working with a therapist or a psychiatrist, can help you walk through that process, or a school psychologist can help you walk through that process, or using one of these advocacy services. Why do individuals with autism present with high anxiety symptoms? So statistically, 42% of children on the spectrum have some type of anxiety disorder. Number one being neurodivergent in a neurotypical world is hard and stressful. And some negative experiences leads to fears of those experiences, like social interactions or navigating new situations. Also, autistic individuals prefer like sameness and predictability and become agitated when, there's changes in plans or there's new situations or changes in routines, creating anxiety. And there's also sensory sensitivity, so they can be like easily overwhelmed in certain environments compared to neurotypicals. So for all of these reasons, we definitely want to be screening for anxiety in this population. There were some questions about just like health concerns present in autism, which is a super interesting one because I don't have a ton of background knowledge in this. So I linked a resource here that gives more information, but there's research showing there's a lot of gastrointestinal problems in individuals with autism. Some of it has to do with just bodily sensitivities. Sometimes they have difficulties communicating distress, and then it kind of gets worse. Like if there are GI issues, especially for kids, maybe sensitivities or allergies or intolerances. And some sensory concerns might lead to like restrictive diets, like if we're not eating like large food groups or certain food textures. Some people advocate for putting their kids on like a gluten-free diet, for instance, which can be beneficial sometimes, but it sometimes leads to a low fiber in your diet, which can lead to a lot of GI problems. So being mindful of that. Epilepsy occurs a lot in this population compared to neurotypicals. So sometimes those like catatonic like shutdowns when we're emotionally overstimulated, be screening for if that's especially like absent seizures, not as the obvious ones like flashing on the ground, but the ones where they look like they're maybe kind of zoning out or not responsive, that would be important to screen for. And sleep problems. So a lot of people on the spectrum have problems with sleep for a variety of reasons. There might just be genetic underpinnings. They might have seizures. they have significant anxiety that gets in the way of sleep. And when that happens, there's increased behavioral problems and distress, and that impacts sleep. And it's a cycle that goes over and over again. So sleep interventions can be really important for people on the spectrum. Oh, here's a question I was talking about before. What can we do to support autistic individuals with substance use disorders? Research coming out these days that autistic individuals have an increased risk of developing a substance use disorder compared to neurotypicals, and that when that does happen, there's a higher mortality risk. And there's a variety of reasons. They might use substances to cope with social difficulties, or to blend in with peers. If everyone's drinking or everyone's smoking, then I will too. Sometimes some research shows that the same areas in the brain activated with addiction, like that reward center, is also activated for like stimming or repetitive behaviors in autism. So there may be like this neurobiological link. So treatment recommendations for substance use in autism recommend less reliance on this like kind of group, less structured interventions like AA or NA and more individualized care. And also just like treating the function of the behavior. Like, is it an emotion coping skill? Can we build our tolerance for distress? Can we replace certain repetitive or addictive behaviors with other behaviors? Can we build our social supports and our social skills? If that's like a proponent, prompting all of these things. So, new question from the audience. Are there any treatment modalities that are known to be more effective in the treatment of behaviors associated with autism, such as co-occurring anxiety, depression, etc., with ASD? So different treatment modalities. That actually gets into my next question, which is, are there special considerations when conducting something like EMDR with individuals with ASD, which I did find a quick guide in there because I'm not trained in EMDR, but so there's more information there. But in general, thinking about, do they need different evidence-based treatments if they have anxiety, if they have depression, if they have suicidality, substance use? Like, not necessarily. Like, those interventions can be really effective for people with autism with just like slight adaptations, like maybe breaking down the concepts more concretely. Maybe you're moving more slowly. Maybe you're also focused on functioning skills in addition to the treatment. So you can do the interventions that you do with this population with appropriate continuing education, with appropriate consultation and supervision. The goal here is to not gatekeep, to not say that, oh, I don't work with this population, so I'm just going to refer out, because sometimes there's no out to refer to. Like, we need to increase access. Balancing that, of course, with our ethical obligation to not be going super outside the scope of our practice if there truly is like more specialized help that they need that we cannot provide. But you guys have many valuable skills that they can benefit from. So I would encourage you to not write it off. And I think that is all of the questions that were provided. I'll give it a minute if there's any other questions in the audience, but I appreciate everyone for being here today. Hopefully you were able to take something with you that was useful that you didn't know before. We have all of our resources linked on our website at ucebt.com. If we're interested in how do we connect families to get a diagnosis, how do we find that in Utah versus locally? What about adults with autism? What about girls with autism? What about autism and gender diversity? What about autism and racial ethnic minority groups? So we have all of those resources linked there. Thank you, everyone.